as a clinical researcher, I spend most of my time working on epidemiology and clinical research, and you're kind of searching for new evidence, sometimes ideally better evidence, and unsatisfied with the uncertainty with what data we have to guide practice. But as a clinician, taking care of patients, as somebody who also does quality improvement work, you're having to take care of patients today and having to decide how we can improve the care of patients today. And how do we apply that evidence, and how do we try to improve the care of infants? And I hope to kind of mesh those two and also to touch many of the points that have been made over the last couple of days in excellent talks on antibiotic use, on how we feed infants, on probiotics, on some of the points that Dr. Kirpalani made this morning. And I do have a disclosure that I will be talking about the use of probiotics, and in the United States this is not an approved indication by our regulatory body, the Food and Drug Administration. I'm not specifically endorsing any product. So I wanted to start by talking about some of the evidence on the prevention of NEC. What do we know today about how we can prevent this disease? And then some of the opportunities and challenges as we try to apply that evidence, and we often do that in the United States, try to do it systematically, and we use quality improvement principles to apply that evidence to reduce the risk of many diseases and improve outcomes, and specifically today really for NEC. And like many of the diseases we encounter, NEC is a multifactorial disease, and I think that's really important to consider as you try to prevent these challenging diseases that have persisted in our babies as adverse outcomes for decades, is that there are many factors that influence these diseases. And I think of it as more of an inflammatory disease than actually an infectious disease. We know prematurity is probably the most important risk factor. The incidence of NEC is very inversely related to how immature an infant is. But over the last decade or so, we've really understood more the role of dysbiosis, or abnormal bacterial colonization, and the influence that it has on the risk of NEC. And I think that has been through newer techniques to understand the types of bacteria that live in our infants' guts. And it's a deadly disease. Case fatality rates are around 15 to 30%, depending on what population you look at. If an infant is undergoing surgery, the mortality rate is around up to 50%. This is really a lethal disease, so one that it's very unsatisfying to try to treat. Really, the effort has to be on prevention, especially with surgery. Treatment really results in high rates of mortality, unacceptable morbidity among those that survive. This is some data that we looked at in the Neonatal Research Network among 25 centers in the United States, looking at when do babies die and what are the causes of death. And we looked at that among extremely preterm infants, those infants that were 22 to 28 weeks gestation, looking at across each postnatal age, what were the causes of death? One of the things that makes often NEC so tragic is that in the early postnatal ages, in those hours and days after birth, when most infants are dying of respiratory diseases, those infants actually there's better survival, fewer infants that we saw over time that were dying of these diseases. But then they go on to the second week of life, second month of life, where NEC is really the major and the most common cause of death for these infants. And in this study between 2000 and 2011, we actually saw that going along with improved survival of preterm infants, the only cause of death that had actually gone up, increased over time, was necrotizing-related, NEC-related deaths. And that was consistent with some reports from the UK by Janet Barrington, and also some reports in Sweden. And maybe it's that these infants who are surviving these first hours and days and maybe the first week of life are now surviving to be at risk for going on to develop NEC. And that was worrisome, but actually starting at the beginning of this decade, we started to see a change. And in 2015, we got the first glimpses of, actually in the United States, the incidence of NEC going down, after decades of really stable or maybe even an increasing incidence. And that was confirmed by reports in 2016, and I think the most convincing data is from 2017. This is by Jeff Horbar and the Vermont-Oxford Network, which covers a large majority of units in the United States, about 756 centers, looking at what happened with the incidence of NEC using their Vermont-Oxford Network definition, which had been stable over this period. And it was about 7% in 2005, and by 2014, the incidence of NEC had dropped to below 5%. And this was really the first time we had seen that NEC in the United States was going down. And this was the same for many of the other morbidities that these authors looked at. We've done some more recent work in the Neonatal Research Network through 2016, and we've seen continued declines in the rates of both NEC and NEC-related deaths. So we've seen improvements, and we don't know exactly what's driving this, but we do think that some of it, and I would speculate that increases in human milk feeding is probably one of the determinants in the United States, as many centers have adopted human milk feeding and donor human milk use. So I'm curious for many of you that are here, that are coming from a variety of different centers, about what's happened in your centers in the last 5 or 10 years with the NEC incidence, with however the way you would consider NEC. If kind of a feel of, has it gone down, gone up? You don't think it's really changed much? Well, it seems like most of you haven't really felt a change in the incidence of NEC. Some more, about 30% decreased, and some increased. And so this is what happened with the NEC incidence at our center. That hospital right there, and this is in the center of Atlanta, that's one of the hospitals I work at, Emory University Hospital Midtown. We have a 49-bed ICU there. We started in 2009 with a NEC incidence that was reasonable, and this is modified Bell's 2A, but really consistent with different ways that we looked at our incidence of NEC. Then it went higher and higher. And by 2013, it was distressing many of the clinicians in the unit. You started hearing nurses saying, what's going on in our unit? What's happening with our NEC incidence? And actually, we looked, and it was 17%. We went through the stages of grief. When you look at your own data, the first stage of grief is denial. So that was our first impression. This can't be true. There's got to be a measurement error. Ascertainment bias. But no, it really was. Actually, it was the number one cause of infants dying in our ICU that were admitted to our ICU that year. And in our Vermont-Oxford network data, we had twice as many cases of NEC that one would expect based on our case mix, adjusted for things like the birth weight and gestational age of infants in our ICU. This was distressing. And we had been trying different approaches to try to reduce the risk of NEC, but there was this sense of urgency. This is unacceptable, 17% NEC incidence. It was distressing the nurses, the physicians. And it led us really to kind of go back and say, okay, well, what's the evidence? How can we try to prevent this disease? What's the evidence we have on the prevention of NEC? And for those of you that do quality improvement, this is kind of an example of a key driver diagram. What we're always thinking of is, if we have an aim, this is kind of a global aim of preventing NEC, what are the causes? What are the drivers we want to tackle in our efforts to prevent NEC? And this is what I would consider some of the major drivers. You could argue that there should be others on here. But these are, I think, 4 areas in blue, which I think are major drivers that we should try to address, and we can go through them. And this is really important for any effort you're taking to really think deeply about the disease and what your understanding of it is, and really to use that to kind of work for what are you going to address, what interventions are you going to address for this driver. So let's go through a little bit of some of these drivers and what we know about the data. And this ties in a lot to some of the talks you've already heard over the last couple of days in terms of the influence of different things we do on the risk of NEC. I think the most important driver, in my opinion, would be non-human milk feeding. We've known for a very long time about the importance of breast milk feeding, ideally mother's own milk feeding, and the risk of NEC. This is a study from the Neonatal Research Network that looked at, in the first 2 weeks of life, how much of an infant's diet was human milk. And they looked at different percentages from all of it. 100% of the diet was human milk, to lower proportions all the way down to no human milk, no days of human milk feeding. And you can really see a dose-dependent effect on the probabilities or survival curves of the chance an infant survived without NEC up to 120 days of age. And really there was this stepwise decline as less and less of feeding was human milk. This is just one piece of a large body of literature that really highlights the importance of human milk feeding, and not just any human milk feeding, but ideally exclusively human milk feeding, because this is a dose-dependent effect. And so that really has to be the big priority. But even among infants that received completely, exclusively human milk feeding, they still got NEC. So although it can be protective, it doesn't completely prevent NEC. Now, some of that could be with donor human milk, and that's been an increase. I know there was some discussion on evidence-based feeding approaches, and I do think the data now is convincing about the effect of donor human milk on the reduction of NEC. But you have to think more globally about the effect of different interventions, not just on NEC, but other outcomes. And one of the other outcomes is cognitive outcome. And I do think there's still some uncertainty about what effect the use of donor human milk has on long-term outcomes of our neonates. There's a trial going on in the United States that we're a part of currently. So I do think breastfeeding, ideally, we should emphasize, try to have mother's own milk as feeding. What about inconsistent feeding? On Tuesday, the infant gets fed a certain way. My colleague comes on Wednesday and decides to completely change the way we're feeding. That was our routine about 5 to 10 years ago. That happened every 2 weeks when we switched. And so I'm curious, for those of you here, do you have a standardized feeding protocol in your center in which you all agree to feed infants in a similar manner with some customization as needed? That's really great to see. The majority of you are using a standardized feeding protocol. I think that practice has really, I think, emerged as something that many of the units are doing. And I think some of the data that supports that is, this is a meta-analysis published in 2017 of observational studies that compared infants who received standardized feeding to non-standardized feeding. These were all observational studies. You can see every single study had a point estimate that's favored the approach of standardized feeding on the risk of NEC with a fairly substantial reduction, risk ratio of 0.2, rather precise estimate because of large number of infants enrolled in these studies, although these were just raw numbers, so we can't account for other confounding influences, but this I think would support the rationale of having a standardized feeding approach. Now, we don't really know, and I know that this was touched on yesterday, feeding slower versus faster, enteral fasting versus trophic feeding, how many days. There's really no clear data that feeding slower reduces the risk of NEC or feeding faster increases the risk of NEC. The SIF trial short-term outcomes that were included in the Cochrane reviews suggest there's no effect on NEC, although we really do have to wait for the long-term data to be published from that trial to really think about how we should feed our infants, not just for NEC, but other outcomes. But feeding protocol, which all of you are already doing, so that's excellent to see. And then dysbiosis, and I think this is another, it's emerged as really kind of a common thematic element of a driver of NEC, or abnormal bacterial colonization. For those of you who were here yesterday in the evening, you heard about kind of the importance of these bacteria that outnumber the number of cells that we have. There's more bacteria in our bodies. And they really are critical for a large number of things that are important in keeping our intestines healthy. In neonates, we have data that they help tighten the leaky premature intestinal barrier so that less things can get through. They upregulate cytoprotective genes. They're important in downregulating the inflammatory response. They can convert things and produce things like short-chain fatty acids that bathe the colonocytes. So there's a lot of these beneficial effects of commensal bacteria, bifidobacterium, lactobacillus. There are even commensal, a large number of these commensal bacteria. And these are acquired, we thought, postnatally after birth, but there may be some data that controversial data that maybe this is even occurring before birth, but these are really critical in ensuring the health of the intestines, and this is for preterm infants, we think also for term infants. And yet in our preemies who we care for in our nursery, there's a lot of drivers that can cause them to have abnormal colonization. This normal commensal bacteria that they need to have healthy intestines is altered. There's reasons for why that could be. They receive medications, prolonged empiric antibiotics, acid suppression medications that can alter their microbiome. They may live in environments that have selected pathogens, potentially selected by high antibiotic use in nurseries. They don't receive breast milk. Breast milk has its own microbiota. It also has prebiotics that help beneficial growth. For example, human milk oligosaccharides help growth of Bifidobacterium infantis. We know that from data in term babies, and so formula feeding, they miss out on those benefits. And I think a little bit more controversial is the effect of being born by cesarean delivery, although more of extremely preterm infants are born by cesarean delivery. That I think there's mixed data on how much that contributes to dysbiosis, but that is another factor that some studies suggest will lower the amount of beneficial commensals such as Bifidobacterium if infants are born by cesarean delivery. I think this was one of the key studies that really highlighted this role of dysbiosis. There were some studies actually before this that started getting at there was something about babies who went on to develop NEC, that they just had different bacteria in their guts. This was by Philip Tarr and Barbara Warner from Washington University, and they had multiple centers, and what they did is every couple of weeks they took a sample of stool from these infants and they followed them along, and they looked and went to see which ones developed NEC and which ones didn't develop NEC. And then they compared the characteristics, the relative abundance of different bacteria in their stool. And you can see that those infants that develop NEC had this really high abundance, what's here in red, of gamma proteobacteria, almost a bloom of that. Even though in the beginning, first week to 2 weeks of life, they started off fairly similar. But then over time, they started to have this bloom and abundance of gamma proteobacteria, whereas the controls did not. Gamma proteobacteria, bacteria like Klebsiella, they're gram-negative bacteria. They are covered with lipopolysaccharide coatings. And this occurred not a day before NEC, but this was even seen days or sometimes a week before NEC. This was antecedent, often before infants even had a sign of NEC. This data has been replicated in a meta-analysis by Mohan Pami, so I think although the differences are a little bit more diminished, this has been consistently seen in other studies looking at babies who develop NEC versus not. And the reason it's important is that one of the things about the pathogenesis of NEC is that premature infants, as part of the development, they have increased numbers of toll-like receptors in their gut, particularly toll-like receptor 4, and this is a receptor that's constantly sampling bacteria. And toll-like receptor 4 samples the lipopolysaccharide coating of gram-negative bacteria like Klebsiella. And one of the things that premature infants also have is that they have a hard time tamping down their inflammatory response. So once they see these bacteria, they see more of them, they develop an inflammatory response, it's hard for them to tampen that down. And so this goes along with a lot of preclinical data that says they're more likely to mount inflammatory responses when they see these gram-negatives, particularly things like Klebsiella, E. coli. It goes along with this role of dysbiosis. Now, we don't know exactly what's causing this. Is it the prolonged antibiotics? Is it the lack of human milk feeding? Is it something actually about the host themselves that harbors this? I think there's still emerging groups that are looking into what's driving this dysbiosis. All the suggestions are that prolonged antibiotics is one of those things that influences this. So if you have abnormal bacterial colonization, well, could you fix the dysbiosis or prevent the dysbiosis by giving beneficial bacteria and probiotics? And so curious here about how many of you are currently using probiotics in your nurseries to prevent NEC? Okay, so about 50%. That's higher than I would have expected. And about 16% of you are considering it. Excellent. So what's the data? Well, this is a meta-analysis that I worked on with Paolo Manzoni and Nina Modi, and we tried to summarize last year the number of trials. And at that time, we counted about 46 randomized trials enrolling a little over 12,000 infants that had studied the effect of probiotics on the risk of NEC. And when you pull these studies together, there's so many that it's probably really hard to read the individual studies in the forest plot. But the risk ratio of the effect of probiotics on NEC was about 0.5, about a 50% reduction, and the risk difference of 3%. Rather precise because of the large number of studies. One of the studies by Kate Costello in the UK. The PIPS trial was actually the largest study that was a negative trial. But even that study, when you did a cumulative meta-analysis and looked at how much did that negative trial actually change our understanding of the kind of overall estimates of effect, it actually changed it very little because there's been so many infants enrolled in these studies that I do think it's unlikely that we're really going to change. It may shift a little bit, but unless there's massive large trials, which are not currently planned aside from one in the US, you're probably going to be stuck with this knowledge that probiotics, on average, across these studies, reduce the risk of NEC by about 50%. There's an estimate of heterogeneity. That's an estimate of how different are these effects from trial to trial to trial, of 14%, so that's a relatively low amount of heterogeneity, fairly consistent. The other thing you want to look at a forest plot is how many of the individual trials were actually to the left of the line showing a benefit of probiotics. And that's important because there are a number of individual trials themselves that also showed a beneficial effect in addition to pooling the results. Now those are trials. What about applying this to routine practice? And one of the things you always want to look at in controlled settings, often with adherence closely monitored, you'll see an estimate of effect here of reducing the risk by around a half. What happened when clinicians decided to routinely administer these probiotics in their nursery as part of standard of care? And fortunately, we also have a large number of studies that have actually characterized that. And so here again is the forest plot. Anything to the left favors the probiotics, and looking at the effect of probiotics on NEC, all-cause mortality, and late-onset sepsis. On the top are the estimates from randomized trials. This is from a previously performed meta-analysis. What you can see is that when you looked at the observational studies, actually more infants have been studied in observational studies, you saw estimates of effect that were very similar to those from the randomized trials, which I think gives you a little bit more confidence that what you saw in the trials when people in their nursery started doing this routinely, they saw a similar effect overall. Although there was more heterogeneity, 60% of heterogeneity, which means that there was a lot of differences. Some nurseries saw a much greater effect than other nurseries. And this was consistent against the finding of death as well as late onset sepsis. So I think that there's evidence of effectiveness as well as efficacy in probiotics. And not only do we see this effect in trials, but when clinicians routinely administer this and we study this in cohort studies, we found a similar estimate overall. So here's all this data, and it's interesting to see that 50% of centers that are here, respondents are using this. In the United States, it's actually a minority of centers. So in a survey done in published in 2016, about 14% of NICUs in the United States were administering probiotics. I think it's a little higher now, maybe closer to 20%. In Canada, this is just a recent study from the Canadian Neonatal Network, about 21% of infants were receiving probiotics. In the UK, based on work by Paul Clark, a survey that about 12% of NICUs, so really still a minority of NICUs, although Germany is probably, at least in reported data, Germany, through kind of national quality improvement efforts, about 68% of NICUs have been using that. And the iNeo collaborative that many of you may be a part of have looked at this and haven't published their data, but there's also some data of kind of fair variation between other European countries in the use of probiotics. So why is it that we have all this data, and at least in the United States, fewer centers are using that, and half of the centers, half of the respondents here are. I think it comes down to what's the right product that we use. This is the data from the United States of what are the most common products that we're using in our country currently. This is based on the 2006 survey. The most common product was Culturelle, which is a single strain Lactobacillus rhamnosus GG. This is actually the most common probiotic on the formularies of academic centers. People have looked at what are the probiotics that are stored in pharmacies, and actually Culturelle is the most common in US pharmacies. The next most common is a single strain of Lactobacillus reuteri, either from two different product types, and then Flora Baby, which is a multi-strain product that is manufactured in Canada. And I think this is a big barrier of which product do you use. We worked with Mark Underwood, who has a lab where they actually test these products, and they can give you a sense of which ones are of reasonable quality. But I do, for those that were here, I do think there's this desire to have high-quality probiotics. Now, in the United States, there is a phase 3 trial that's going to be started as the first trial to actually go for creating a probiotic that's actually a drug and not a dietary supplement. It is going to be a large trial, and so we'll have to wait a few years, but it's going to be using a Lactobacillus reuteri as their strain for their product. Importantly, if you look at most meta-analysis and try to say, is one favor single strain versus multiple strain? Is there evidence of clear heterogeneity? I think that the evidence is mixed, but there's probably no clear, consistent data that says multiple strains are better than single strains in many of the meta-analyses. What about abnormal intestinal oxygenation? This is the fourth driver. We have known, and there have been many studies about the role of ischemia in NEC, and I think more recently, one of the compelling pieces of data has come from the NeoProm collaborative, and this is a collaborative of individual patient data meta-analysis of all the oxygen targeting trials that looked at infants who were targeted with lower oxygen saturation targets, 85 to 89%, versus higher targets, 91 to 95%. Many of you are familiar that these trials showed a higher risk of mortality with lower oxygen saturation targeting, but the other finding that was substantially different was that there was a higher risk of necrotizing enterocolitis in those infants that were targeted with lower saturations. Absolute risk difference of around 2%, relatively low heterogeneity, a significant finding. And so there was something about lower systemic oxygen saturation and higher risk of NEC. And of course, what determines oxygen carrying content in your blood is largely how well your hemoglobin is saturated, but also how much of that hemoglobin do you have. And you heard Dr. Korpolani earlier today talk about the role of potentially of anemia as a cause of NEC, and I think both of those things have to be considered together because many centers have shifted how they target oxygen saturation after the results of these studies. But what we found, this was a prospective study where we tried to understand in a given week, looking at serial measurements of hemoglobin, or serial assessments of whether an infant received a red cell transfusion, was either of these exposures associated with the risk of NEC. We did that using something called time-varying covariates, which accounts for the changing nature of a baby getting transfusion in 1 week or not getting transfusion another week, or being anemic in 1 week versus not in another week. And what we found is there was actually no association between red cell transfusion and the risk of NEC, but as you saw earlier this morning, there was an association between the severity of anemia, and we used a predefined cut point based on the lower thresholds of trials that have been done to date. Rather imprecise association, so I think we couldn't estimate the risk well, but it was a significant finding. And we ran a large number of models to see how many times did this risk factor show up, and it showed up 70% of the time. And in general, risk factors that show up more than 50% of the time are reliably associated with the outcome of interest. So I think this is observational, so I think I'm still a little cautious about saying this is a cause of NEC, but we will hopefully have some data. You heard about the Transfusion of Prematures trial that's finished enrollment. And if people adhere to these thresholds, in one arm, you won't let the infants have a hemoglobin that falls below 10 or 100 for those that use different units. In the other group, you'll let the hemoglobin go potentially as low as 7. And I think this trial, although NEC is a secondary outcome, it's not the primary outcome. When you look at this trial, that will have 1,800 infants, plus the ETTNO trial from Germany that will have a little over 1,000 infants in the prior trials. I think when you combine those, you may get an understanding of the potential effect of anemia on NEC. But we'll be a little imperfect because many of the centers over this period have changed how they target oxygen saturation. I think that is also something that's going to influence how you deliver oxygen to your intestines. So if these are the drivers, what are the interventions? If you're thinking now about prevention of NEC, and you've gone through what are some of the data of what's causing it, how can you apply the interventions? And so how many of you have worked on a quality improvement project at your center specific to NEC? It's about a little under half of you have worked on this. So This is a challenging disease, I think, because of the factors to sometimes prevent. But there actually is a lot of data to say actually that people have been able to move the needle on NEC through quality improvement projects. This was a summary that was published a couple of years ago looking at different groups. Some were single center, some were multi-center collaboratives, and their efforts to reduce NEC or large multi-outcome efforts. And almost all of them reported declines, some of them by over half, in their risk of NEC through the application of quality improvement methods. No new FDA-approved drug in the United States to prevent NEC. This was largely applying what we have known for many years into reducing the risk of NEC without any real new therapy. But they showed a lot of success, and this led a lot of people to get encouraged. And so, again, with our key driver diagram, we set out in 2013, really getting heartburn a lot about the risk of rate of NEC in our center to try to get down to 5%. That was below 5%, which was around the average of what the Vermont-Oxford network was showing, to try to at least get to being average. That's, I think, an ambitious effort to reduce it by over 2/3. And these were the interventions that we worked on. Much of the evidence that you've heard about today: increasing maternal breastfeeding, introduction of donor human milk, developing a feeding protocol, not only having it, but monitoring how well did clinicians adhere to it. We introduced probiotic supplementation, we reduced acid suppression use, we worked on decreasing prolonged antibiotic use, delayed cord clamping. All of the things that you would think have reasonable amount, some better than others, of evidence to support the reduction in NEC. But we didn't just write it in a guideline, because then you can't be sure if people are actually doing this. We actually measured our care to make sure that we were actually doing what we thought we were doing. And we did. We reduced acid suppression use from 27% to almost 0%. We had increases in delayed cord clamping. Probiotic use, the majority of our infants in our unit received probiotics. We got to a median of 100% of human milk use, largely through the introduction of donor human milk. We had pretty good adherence to a largely nursing-driven feeding protocol, about 90%. So you should say we're providing good care. Towards the kind of title of this talk, we were doing everything right. We should see a reduction in the risk of NEC. That's what you would expect. All these things that all should have an impact. And yet we saw no effect on the risk of NEC. This is a statistical process control chart looking at kind of quarterly incidence of NEC. The spike right here above this dotted red line, which is the upper control limit, goes along with that 17% incidence of NEC that really got us coalesced on saying we've got to do something. Even though we had started things like delayed cord clamping and reducing acid suppression use, we began donor milk, probiotics, feeding tube care, feeding protocol, and yet we didn't see any effect on our risk of NEC. In fact, we actually saw a little bit of an increase. Of course, people in our NICU were wondering, well, maybe should we just rip out all the floors and change all the walls? This is just a bad microbiome in the unit. You know, you can get carried away, really, when you start in this spot about creative ideas and really quickly go down the rabbit hole. We did use LGG, and this was our experience that we published looking at kind of pre-LGG implementation and post-implementation and the risk of NEC. And actually, as I mentioned, we actually saw that NEC had gone up. No effect on sepsis, but no cases of LGG-associated sepsis. And when we accounted for differences in case mix, we saw actually that our risk after probiotic implementation with pretty good adherence had actually gone up. And this was disappointing. This shouldn't happen. I just showed you the data that it should actually cut our risk in half, not increase it. I think one thing with quality improvement is what was probably happening with trials years ago before they had to be registered, is that often people see all the successes, but we don't often share in the world of quality improvement the challenges. If you talk with many of the centers when they say, yeah, we're having the same trouble, we've been working on this for years and we haven't reduced our NEC rate. And I think there's opportunities to kind of learn from that. So what do? Now you have a bunch of our nurses and physicians thinking that I don't know what I'm talking about. I told them 5 years ago we would reduce our risk of NEC, and we have still not moved the needle. I think it has to come back down to, as a quality improvement, putting my quality improvement hat, you have to come back to your key driver diagram. This should really be a framework that you think deeply about. and to try to come back and say, this is what we said, what the best evidence today says is the risk factors for NEC, and what we think are the reasonable interventions. What haven't we done? There was one thing we hadn't fully targeted, and that was prolonged antibiotic use. We know babies need good bacteria. We were part of a Vermont-Oxford Network collaborative that tried to get the rates of antibiotic use. They had set 25%. Many centers, some centers probably in Europe, had participated. And we did, through several tests, actually reduce by about 25% our prolonged antibiotic use, and we've been working on this actively, trying to even get a little bit lower. We also try to have an opportunity, every time an infant got NEC, there needs to be a sense of urgency for these outcomes to develop. So every time a baby in our unit developed NEC, we did a huddle. Got the team together, nursing staff, the physicians, the practitioners. We went through a checklist and said, what were all the potential risk factors? What were the protective factors this baby should have received, whether it was maternal breast milk, antenatal steroids? Did they get those? What were some other characteristics? It helps to actually reinforce your team to really think about these things. Think deeply, and actually we've collected this and looking at, after you do this for 10, 15 patients, you actually can then do a Pareto analysis and say, what are the big drivers in our center that we're seeing as risk factors? Because at some centers, dysbiosis may be a major risk factor, but I think the distribution of those drivers at any given center may vary, and that limits the success of a generic toolkit approach to saying, just do X and you'll reduce the risk of NEC at your center. I think it is important to get a sense of what your drivers are. We've continued to work on this. When I started, I did my QI training, went to Cincinnati Children's, and the people there said, plan for multiple years. It was a one-year course, and I said, oh, in 1 year and they said, no, you should give yourself many years for this. And so we worked on reducing antibiotic use. We started NEC huddles. We actually went and changed our product, and we're now using Lactobacillus reuteri product in our infants. And so we've had a few quarters, which we haven't had in a long time, in the green. Two quarters with no NEC, one lower, and so I think we still are uncertain, but we have to see, but we are starting to see potentially that we're moving the needle a little bit. Whether it's from these interventions or other things, it's hard to know. But these things probably interact. If you use lots of antibiotics, maybe you diminish the effect of probiotics. If you do delayed cord clamping but tolerate lower hemoglobins, maybe that diminishes the benefit of delayed cord clamping, and I think that's important when you think of multifactorial diseases. There's probably interaction with a bunch of these care practices. And so I do think that there's experiences from many centers that support the potential benefits of quality improvement initiatives to prevent NEC. And probably the safest thing, and the least controversial thing, is really to invest a lot of effort in human milk feeding, ideally feeding mother's own milk. But it is, as NEC is multifactorial, I think you really have to think as you go out to reduce these diseases, much like BPD and others, that really thinking about addressing multiple drivers, and that means plan for a long time frame potentially. If you achieve it earlier, that's great, but these are things, and you have to think really about the key driver diagram. What is the data you believe from the external evidence, integrating with your own NICU, your own experience, that you think can be done? But this work also suggests really that we need to understand, we fully still don't understand what are the causes of NEC, and also some higher quality evidence to guide prevention efforts. This is our teams over the different projects that we've done over the years. And I did want to put a plug in for 2 conferences for organizations that I care about. One is, if you're interested in NEC, the NEC Symposium is a meeting this summer in the United States that's focused exclusively on NEC. You can see the web address there. And then all of you have heard about the EBNEO conference that will be chaired by Dr. Boyle. And so come visit the US, go visit the UK, and thank you very much for your time.